And I think everybody knows him, so he doesn't need much of an introduction. But just to kind of briefly, he's been here at ECU for a long time, did his undergraduate degree in biochemistry here, and then left for a little bit of time, was at Chapel Hill for a while, and then has been back here since 1991, working in the Division of Nephrology, our former chief of nephrology and now chair of medicine, and has done innumerable projects and research studies in transplantation, is a member of the American Society of Transplant Physicians, and I couldn't even detail all the papers that I was reading about, so I'll go ahead and let you take it from there.
That's very kind of you. So on October the 5th in 1970, a young Sudanese fellow presented to St. Mary's Hospital in London following renal transplant. He was not quite a year out, presented with acute renal failure, actually had evidence of Polyoma was obstructed, and found to have distal ureteric stenosis. He underwent a urostomy, I always say that wrong, and they attached his ureter to his native ureter, and they resected the ureter segment, which you see a electron micrograph in the picture here in front of you. And what is characteristic, and boy, this laser pointer I have has officially finally died. But the characteristics you see in the nucleus in that cell are important. And what you see is a very prominent nucleolus within the nucleus, and more importantly, the peripheral rimming of the chromatin, which is not specific necessarily for BK, but it is not uncommon in several viral entities. This patient, this specimen, and this work went on to immortalize this individual's name, of which I do not know his name, and his initials, of course, were BK. That was the transition time from where we used to name it after doctors to where we are today, and so they immortalized this virus with the initials of the patient. This was published in June 19th, 1971. Cortland, I'm so sorry, I'm getting senile, I forget the years. So I wrote it down this time so I won't forget it next time. In Lancet in a back-to-back report, and actually, believe it or not, when I was in, I looked through my old copy of Robin's pathology, and I remember in medical school I learned a little bit about JC, learned a lot about SV40. I didn't know what BK was, but in fact of the matter, yes, I did go to medical school after 1971, but BK and JC were both described for the first time in one edition of Lancet in back-to-back articles. The first case of BK coming from St. Mary's Hospital in London, the first case of JC coming from the Madison VA on our side of the pond. And they were really the first two clinically significant polyoma viruses that we knew that were specific to humans. So today, the title, I think I messed up a little bit. I'm not going to talk about all viruses. I'm going to talk about polyoma viruses today because there are several that come into play. There are 19 known polyoma viruses, of which 5 affect humans. That is of the time of my last review. It might have changed a little bit. I tried to review things. I apologize for the timing for this. I should have thought better, to do this right after the ATC, because I know there's a lot of trials that will probably be coming out in the ATC. The ATC abstracts just got in on Friday, so I don't have any preliminary data on that. But I know there are a number of trials. There may be some new data on some new stuff. BK and JC we talked about. There are 2 other varieties, W and KI, that are named after the institution, WashU being the W, the institutions that discovered them. They both cause, right now there's controversy as whether W and KI actually cause renal failure. We know they both cause respiratory syndrome. All of these viruses, with the possible exception of Merkel cell, actually cause respiratory syndromes, and those of us, and many of us in this room, by the way, do have BK within our cells. They probably got it as some kind of respiratory illness. But they are really the big players. I won't come back to Merkel cell, but as you know, that's associated with skin cancer and probably will one day be very responsive to specific antiviral therapy. So these are the 5 players. I have tried, as I think many of you have worked with me trying to do this, Had a couple of people that they called polyoma virus on a biopsy, and they were BK negative and subsequently JC negative, and we tried to obtain PCR measurement of either W or KI. And I'll be honest with you, they may can do this in St. Louis, but can't do it in Greenville. I tried pretty hard, but I just couldn't get there. So, an important, I think, point to make from this paper is that some people screen for decoy cells. I'll show you pictures of those. I think most of you know that's just sort of I call it the pap smear of urine. It is a highly sensitive but yet very nonspecific screen for polyoma viruses. But in a study, a cohort of patients where they were looking with decoy cells, 27% were found to have only JC virus. I think that's a wake-up call for all of us. And of those, 6 developed JC virus-associated nephropathy. And I'll actually come back and show you other patients that have problems with this, specifically HIV patients. BK can cause pneumonitis, hepatitis, retinitis, hemorrhagic cystitis. Very important in bone marrow transplantation. And there's actually a couple of reports, I didn't put it on here, of actually CNS manifestation. I'm not by any shape or form trying to suggest that it causes PML. But I will tell you, every year the data on BK and JC mature, the more these two viruses get closer and closer to what they do. So just stay tuned. This has a fairly wide repertoire of problems that it can cause. Other places you see it is obviously other solid organ and non-solid organ transplants. And actually there are now several reports. And of course Ron Falk believes that HIV nephropathy is caused by some as of yet undiagnosed viral infection that is treated by heart therapy. And I think he's right about that, by the way. But we have actually diagnosed both BK nephropathy, and now there's a couple of cases of JC nephropathy in HIV treated, in HIV patients. So what it looks like. So I'm going to work on the magnification on these. I apologize. But if you look at this little cell right here, you can sort of see the rimming of the chromatin in that nucleus. This is obviously SV40 staining. Look, drilling down onto one here. Always look for the arrows for the fellows. This is a positive arrow sign here that's very important. And Reggie, that'll come back to haunt you in a few moments. You can see this a little bit better here. These are not concurrent back-to-back slides, obviously. But you can see some of the characteristic detailing in some of these cells. This is a PAS, and obviously this is a laser pointer who doesn't like my fingering. Sorry. But you can see the SV40 up there on the top right staining again. Shake it.
Can you use the mouse?
Oh, duh. Thank you. I hope that duh comes over on the internet. I like that. What are the risk factors for BKV? And this is, it takes the touch. That's why I can't play violin. Great, thank you. This is a cool one that's coming out, guys. I know of 2 OPOs that are in the middle of a trial for this. We may end up with BKV, same place where we are with CMV. We now have data, developing data, I'll say, that a BKV seropositive donor to a BKV seronegative donor by antibody testing is a risk factor for developing BKV, especially in retransplantation. And I'll present a couple of slides on that at the end. The rest of these are really, with the exception of one, just a hodgepodge of things that are actually, exception of 2, of things that put you at immunologic risk. Obviously, age greater than 55, I love that age, sorry. Male recipients, not sure what that is. Maybe they have a longer ureter, who knows? I mean, it's I don't know. There's a lot of differences, and prostate, who knows? I don't know the differences there. Donor age, greater 65. Again, that may play into that whole seropositive to seronegative thing. HLA mismatch, I think, is obviously an immunologic issue. Acute rejection, ditto. African American, ditto. Retransplantation, ditto. And pediatric transplant. And as Shao will tell you, the kids have a much more robust immune system. And what we do with reducing immunosuppression in our clinic, Shao would stone us if we did that in a kid. So it's a different immunologic animal. Ureteric stenting, I know Karen was there with me last year, and around the corner from our poster, there was a series of about 7 posters, and one was ureteric stents are a risk factor for BK. Next one, ureteric stenting is not a risk factor for BK. Back and forth and back and forth, and it's great fodder for some meta-analysis maybe one day, but I don't know where that answer is, but I can't give you a solid answer on that. So, you know, we sort of blew through the whole decoy thing, which I'll come back to later today, but most people are not doing decoys, and if you look at the ATC guidelines, most people are either screening by 10 to the 7th measurement of urine PCR for BK or 10 to the 4th for plasma. And since you're a little closer to it than I am, you can read the relative specificities and sensitivities of those tests. I think the time variable on this, and I'll present some data on this later, is probably more important than the raw sensitivity and specificity, is when in the time course, and I'm going to actually make some recommendations about that and get to the end of the talk. I apologize, I was cutting and pasting a whole lot in this talk, but this is a great study, and if you can see the x-axis here, that's in days, and they're in century marks, 100, 200, whatever. And what you can see is in the solid line of viremia, which I think is the most important of these are cumulative incidences, so keep that in mind. You know, once you're there, and it keeps adding to them. What you can see is you got most of the action that's going to happen with viremia has already occurred early on. Now, there's huge bias in this data about how you run your screening program. Obviously, you're not screening it, you know, there's nobody there to hear the tree fall, right? The tree didn't fall. So if you're not screening, and that's probably the disparity there between the viremia and the actual presence of BK-associated nephropathy. But it occurs very early. Now, this is a very important slide here. And the reason why it's an important slide is this is not, you know, like OPN or, you know, the SRTR data. This is, you know, a cohort that was followed. On the x-axis, you see weeks. It is a variable x-axis over to your right. As you see, you get up to 1 year pretty quickly. But what you see in the solid line here, I just don't have the touch. I'm going to move to the mouse. Sorry. What you see here in the solid line is viuria. And you notice that peaks at somewhere around 10 weeks, but really, I mean, effectively is there by 4 weeks. But what you see is a lag in viremia. And one of the things I hope we can discuss after I get done here is I think we should actually move to screening our transplant patients early on with viuria because it's a lot cheaper, and then only roll those over into viremia screening that are viuria positive. I think that could be a very cost-effective way to approach this because you'll pick it up early. And those of you that have been around the block with BK know this. Treatment and early intervention in BK is 10,000 pounds of cure. And so this may give us a couple of weeks head start on this by, again, screening for urine before we screen for blood. I apologize for the size in this again. I'll be the first to say that this is from the SRTR data set, and so this is what it is, this data set. You know, there people make their careers mining these data sets. I think they give us a reflection of truth. I think they're important to look at, but they are not randomized controlled trials. What you see is confidence intervals for various immunosuppressive agents taken at 6 months, 12 months, 18 months, and 24 months for the presence in the SRTR database for developing the presence of BK. And as you can see, cyclosporin moves from something in 12 months around 1 to about 1.7, but look at TAC, and TAC blows up into around 4. I'll come back to the timing of that in a moment. It'll blend into some later comments I make. Azathioprine-based, I would discount that data. I know it looks very promising. Everybody in Europe at least loves azathioprine, but look at the N number, guys. It's 392 cases compared to 36,000 for TAC. I mean, you know, I'm not sure I'm not sure of the data, to be frank with you.
Is this urine or blood? Serum?
These, I'm pretty sure, are serum. Yes, TBKV, yeah. And they, and then MMF you can see, It goes up, not quite as strong as TAC. I'll come back to that in a moment. Probably the most important one is down at the bottom is of course, no mTOR means everybody else, right? So you see that is a positive risk up to 3.61, whereas the presence of an mTOR inhibitor confers possible protection through about 18 months. And I'm going to present some studies about that. Is certainly a strategy that I think we should take. Now, a lot of people have argued, well, where did BK go? It was discovered in the early 70s, and the first case in a transplant patient was published out of Pittsburgh in 1990. Was discovered in 93, was published in 96, forgive me. I think we saw our first case here about 98, somewhere around there. And of course, it's not surprising. I mean, Pittsburgh is the center of the earth for Prograf. And I think a lot of people are really moving that the really low-hanging fruit here is Prograf. The whole interesting interplay between Prograf and, TAC, forgive me, tacrolimus, and MMF and intrahepatic recirculation. Some people have argued the only reason why tacrolimus is better than cyclosporin is it has no innate differences as far as its immunosuppressive abilities, but all that it did was took a cyclosporin-based level of MMF and jacked it up to a tacrolimus level because of the issues with intrahepatic recirculation. So something went on. Bottom line, MMF came out in the mid-90s. It was only approved in 1998. But it came out, people started using it. 90% of what we do in transplantation is not FDA approved. It was started using it in the early 90s. Something happened in the mid-90s. And it's hard to really attribute that to MMF or to tacrolimus. It may be both. And I'm going to present some data later in this talk that MMF is probably a little bit more of an issue. Donor status we talked about. This is looking at the onset of viruria. Again, not the hardest marker on earth on the x-axis is days. You can see patients who their donor was positive have a much higher prevalence, of developing this over time. What is more impressive with this, if you, again, you're looking at antibody status, just like we would CMV, look at the curves for increasing titers in the earlier and earlier and earlier onset of these Kaplan-Meier plots of developing viruria. So, like I said, our OPO does not do this yet. Every now and then you'll get a kidney from one of these OPOs and it'll be on the sheet and you're sort of like, what's that all about? Well, this is what it's all about. People are starting to look at this. This is a decoy cell. This is a pap smear on the urine, basically. And it's really nice, and you got the error up there, Reggie, so you can see the rimming. Not a very prominent nucleus, maybe there. Same thing here in a tubule, just a different place. Nice cast, and again, if you look real closely, you guys that are closer and don't have the visual issues I have can probably see some of that rimming in there better than I can from here. Now, this is the interesting thing Chapel Hill is doing. We're going to have an MRI scanner in our department in a few months, and so we might be able to pull something like this off. We can't do it right now because I can't imagine how hard the radiologists would laugh at us, but they basically spin the urine and do an MRI on it. And these are called Hoffen. I hope I'm pronouncing that correctly. There's some Europeans involved in naming this thing, so there's no telling what it stands for. But the accuracy, and Randy Detweiler and Sharon Singh have really been the big proponents of this. Nicolette Volker has been involved as well. But they got some really good sensitivity specificity data. Again, we have access to an MRI machine and we can pop a tray of these things in there and scan them. Maybe we could get some pretty cool data like this ourselves, but it's a very interesting potential technique. All right, so Reggie. Well, actually, who else is here? What was the first year? Oh, Nirif. Good. So Nirif. So look at these arrows, right? See that rimming there? See those little circles? It's the BK virus talk, and they're arrows. So what are these cells that I'm showing you here?
These are the viral units.
Reggie, you want to help him out?
Yeah.
Okay, so notice these have a very dense central nucleus with pallor around them, and they're very small. In contrast to this cell over here, or even more so this cell over here. And notice this guy here looks a lot like this guy right here. And notice that he has crossed over the basement membrane. I'm sorry? It's a lymphocyte, absolutely. And why is this so important? Because a lot of times where you're going to see BK nephropathy is in a patient who has been treated for rejection. And so this patient has tubulitis, obviously out here. He's by definition got, she, I don't know, 3 that I can see real well of lymphocytes on the wrong side of the basement membrane. And sorry I was hiding from this from you guys, but then the side by side SV40. And now suddenly you can say, oh yeah, there is some rimming around there. So this is the big, so when you get something, the next time you get something from Carlene or Vanderbilt and you say, those idiots, why can't they do that? Well, just think about what y'all just did. It's hard, and these are lymphocytes, and they're not, this is not a BK viral inclusion, that's a lymphocyte, and these guys, the big guys, and I got some better slides of this going forward. So this is a real classic one here. Look at the rimming, and look how big. Look at the nuclei here. Look at the nuclei here. This is more along the lines of what you would see in tubular epithelial. Look at the size of this nucleus. And again, the condensation of the chromatin around the rim. So in many ways, it's the mirror image, if you will, to overuse the statement possibly, of what you see in a lymphocyte. Instead of it being small, it's big. And instead of it having circumferential pallor, what you're actually looking at is the nucleus, and you have the chromatin staining. So they're very different appearing cells, but a lot of people get them confused. The pathologists love to grade things, so they've graded BK into 3 classes, A, B, and C. It's almost like my kids' report cards, but they don't see many of those. They see the other letters. And as you see here, there's not a lot of damage to the architecture. Again, just by low power, considering what we said, you can see that a lot of these cells and some of these tubules are really big. I mean, these nuclei. And again, if you look up here with the SV40 staining, you can see that this is positive for BK. This would be a stage A. Stage B, seen here, you got a lot more lymphocytes, but you know, you don't have to scratch your head to recall that this is actually a kidney. And unfortunately, stage C is this, which is this really tore up. I'm going to pause for a moment to go to a different place in this talk to tell you that one of the things I'm going to talk about later today is that I do this, and I know the ATC guidelines actually mention this, but the reason why IVIG, and people even advocate a short course of steroids early on in the course of BK nephropathy, is that it is an incredibly fibrosing virus. And so not unlike what we do for AIDS and PCP pneumonia, you know, you pop them with some steroids early on. Many people are advocating an early course of a short, you know, like a week of some steroids or giving IVIG. And I think this picture illustrates this, and that's why I chose to bring that up here. If you look at graft loss on the far right, going down vertically, you can see as you move from an A with a 13% graft loss. And again, I think you guys have not lived through what, if MJ were here, she could tell you, or actually Karen could tell you. I mean, used to, if you got a diagnosis of BK nephropathy, you're going on dialysis. And now if you catch this stuff early, you have very low chance of graft loss. And of course, if you wait to stage C, there's a 100% chance by this series. I'm not a big flowchart kind of person because I've never seen a patient who fit nicely into a flowchart. I will just tell you the ATC presently recommends Q3 month monitoring for a 2-year period. I think we need to morph that. I think we need to screen actually more frequently. And hopefully at the end of this, we'll have time to discuss maybe we could move to a more frequent viruria measurement in the first month and roll over into a viremia measurement. This should actually be monthly for a couple of months and then move to every 3. I know it occurs, as many of you have seen, but it's also out of context when I get a 10 to the 4th measurement, or more usually it's a 10 to the 3rd measurement. of someone in their blood to have BK, they're creatinine 1.1, they got a smile on their face, and what to do. Usually I will back off their immunosuppression, will go away, and there will be a hiccup, and that's about it. But I think after some of these trials come out about sirolimus and everolimus, I think there's going to be a lot of changes to some of these guidelines, and so that's why I would not focus too much on them. We, as a center, have moved to viremia being our choice, and 10 to the 4th is the magic number, and Q3 months is sort of the vanilla in that. But we may change that a little bit before some of this data comes out. If you're a worshiper of epidemiology, I guess, and you like Cochrane grade data, there's no data to support anything I'm saying today. That basically is what this slide summarizes. There's no data that one agent is better than any other agent. And this paper by Hirsch and Dr. Brennan actually has written a very similar article where there was no evidence that one agent was better than another. This is actually Dr. Brennan's work in collaboration with Karen Hardinger. It's a very cool study. It got a lot of press. And what they did is they had 5-year survival of patients that had BK nephropathy that was detected very early. As you can see, this was eventually published in 2010, but they started actually way before 2005. I think they started closer to about 2000. And the only thing they did to these patients was back off their immunosuppression and got these incredible results, which you see graph survival and patient survival. And there's a graded response, as you can see, as you move from left to right, as you move from no viruria to transient to sustained viremia. So very nice stepwise reduction in survival as risk goes up. But overall, the population did very well. And again, none of these patients had anything but a reduction in their immunosuppressive agents. At the time that this study was performed at Barnes, they were a CAMPAS center. The vast majority of these patients were actually treated initially with complete cessation of their antimetabolite because of neutropenia associated with CAMPAS. I'll be honest with you, in discussions with some of the investigators in this trial, they have suggested that if they did not have neutropenia, considering the data that is present today, they would choose to decrease tacrolimus as their first agent to decrease instead of the MPA derivative. And that, by the way, guys, is why you may look at me cross-eyed every now and then when I tell you to back off the tacrolimus instead of the MPA. Is some of this data. But again, in this data set, they backed off the MPA first, and actually stopped it in many patients. There's a mechanism not dissimilar from leflutamide. I'm not so sure about the data about leflutamide, but if you look at various kinase inhibitors, BK virus is dependent upon many of these pathways, so from a mechanistic standpoint, it should not be surprising that an mTOR inhibitor could have direct antiviral activity against polyoma viruses. Now, this is sort of a complicated slide, but I think it's a very cool slide. These are in vitro data looking at T-cell responses to lymphocytes grown in a media of various concentrations of tacrolimus on the left here, these two, and cyclosporin on the right. They were stimulated, these T cells were stimulated with various capsular proteins of CMV and BK virus. And the cool part of this study, and I'm not smart enough to know if a TAC level in a Petri dish of 6 is the same thing as it is in me. So that caveat being there, it is quite fascinating that the steep part of this slope for TAC, for response to CMV, occurs about where we like to run people. And if you look at 3, there is no decrease in the response of the lymphocytes to this antigen stimulus. But as you move from 6 to 12 to 24, well, you see the picture. To BK, a very similar picture with the same axis on the x-axis for the tacrolimus levels. Similarly for cyclosporin, you see ranges of drugs that we use, but in contrast to what you see for TAC, and this is another brick that I'm putting on this pile of why TAC is probably more problematic in BK than is cyclosporin. What you see, again, we try to run patients 120 to 240, complete robust responses of lymphocytes to these stimulus antigens. And not until you get up to above, I think that's 900 right here. I can't see these are not levels that we deal with physiologically. Again, within the context that these are in vitro data and not in vivo data. Similarly, mycophenolate, this is a very cool slide looking at the same kind of study. As you know, I quote you guys the whole 1.6 data point, which would be right here for a mycophenolate level, for those of you in the room that believe in mycophenolate levels. Leflutamide, I've never met a leflutamide level because it takes 6 months to get them back, it seems like, so I can't comment on that. But I do know that for sirolimus, this is a very heavily weighted sirolimus level, and there are similar data for everolimus, by the way. I just didn't choose to show those to you. But again, looking at BK virus, capsular proteins, EB virus, similar, and CMV, the amazing thing that you see for an agent that is touted as potentially useful in this compared to two agents that we use for immunosuppression, there's effectively no difference in these viral responses. So these data that are in vitro, and again with the SRTR data that I showed you, is why that I've come, and I think we've been very, very successful here with this, guys. And you will see me do this. I back off the tricholomous first, and then back off the MPA second, and we just did that with a patient this morning. We actually are coming out of it, and we're flipping things back around. I apologize that this data has not matured any since the last time we visited. I do know specifically of 3 trials. I'd love to be in one of them, but we got so many trials going on, we can't take another one on. But there are 3 big trials going on looking at utilizing sirolimus to prevent BK nephropathy, and they're ongoing. And I'm sorry, I don't have any more data beyond this abstract that came out in ATC last year. This is a very, very cool slide. Dr. Brennan once told me, I've heard him say this in public many times, that the presence of BK virus is the world's greatest immuno. And I will tell you, having done this, and MJ's here now, she can agree with this, in the old days, we put a kidney in you, we gave you a bunch of drugs, and we watched for your creatinine to rise. And nowadays, we have many other early warning radars. I'm actually, believe it or not, starting to believe in immunos. We have proteinuria. We have all these things that are out there that we can adjust. The really cool one lately, of course, is DSAs, and as y'all probably know from some of the work we've done, that we're actually dialing immunosuppression on the basis of DSAs now. But the cool thing that they demonstrated here, if you look out on the x-axis beyond survival, AR is acute rejection, PVN is polyoma virus nephropathy, CMV, EBV, and all badness out here to the right. On the left of each of those paired columns are patients that participated in a program of BK screening, and on the right are the controls that did not. And what you see is almost a tonic effect or a tide effect upon all over immunosuppression, because going back to Dan Brennan's comment that this is a great measure of over immunosuppression, if you're monitoring for it, you're dialing down your immunosuppression. And these markers that you see here on the x-axis going out to the right were actually decreased despite no other therapy for it, just because you were running a more appropriate level of immunosuppression. And I think this is a very beautiful thing that we're beginning to see in transplantation. A lot of agents out here. This is just to show you one that sort of fell on its face. FK778 is another, I think this is actually a leprosy drug or rheumatoid arthritis or something. And it had some activity against BK. It is a third cousin of leflutamide, by the way. But it just failed. It had a lot of bad problems, and so it did not work as a potential agent. The agents that are touted, I think this is in actually the Hirsch paper, if I can see above the screen here. No, this is Alex Wiseman's paper from Denver. Cidofovir is a treatment. I'm going to come back in a moment and show you why I don't think that's a good idea. We use leflutamide. Again, my bias is I'm not a big fan of leflutamide. IVIG, I've certainly used acutely up front. And as many of you guys know, I'm a big fan of fluoroquinolones, and I'll come back to some of the data. This is a DNA virus, as many of you know, and it is ciprofloxacin, as you also know, it inhibits DNA gyrase, and so it has actually activity against viruses. And many of you remember, Reggie, I think it was you who presented the paper out of Brigham that they showed in a retrospective analysis, non-controlled, that patients who got put on Cipro because they had allergies to Cipro had much less prevalence of BK, I forget, was it nephropathy or viremia, but they measured one of the outcomes from it. And I'm going to show you some things I wish we would do around here in the future. Cidofovir is actually toxic to mitochondria in the proximal tubule, seen in some of these slides. And those of you that have the misfortune of having to go to this it's a bad drug. It can eat your kidneys alive, and it's just not a very nice thing. And it's sort of a sad, just a paper I pulled out that showed that in the patients who got cidofovir, they actually didn't clear the virus any better, and their creatinine got worse. And there's a lot of data out there to support that. And I'm afraid if you're pulling the cidofovir gun out, you might as well pull the permcap gun out. There's a new alteration, I'll call it, a 1-hexadexylcyclopropyl, I think that sounds like, cidofovir. This is looking at an immunofluorescent technique to detect replication of the BK virus, moving from the top at 24 hours down to 96. On the left column, you can see pretty constant pattern of immunofluorescence. The right column is cidofovir, and as you can see, it sort of finally catches up and does something. Pretty good replication up in the early hours, but with this code name CMX001, seems to be a little bit stronger and is apparently less nephrotoxic as well. I have not heard any more about this agent. I don't know where it's at. It may be in some trial, and that's why you're not hearing about it. That may come out one day. A couple of big issues that you probably haven't thought about is retransplantation. I'm going to approach this two different ways, one survival, one nephrectomy, when is that indicated. A chop of the OPTN data from 04 to 08, there were 823 graft losses that were attributed in that data set to BK nephropathy. Again, the trouble with this data set is there is no control of how BK nephropathy was diagnosed. That could be with or without the biopsy, unfortunately. Of those 823, as you can see, 126 received the second graft, and only 8 of those 126 were lost, and of those 8, only 1 was due to BK nephropathy. About 17.5 of them had BK viremia, I believe I'm remembering that correctly, which is a number that's not, inconsistent with what people may see in other situations. Now, I have no outcomes data, so this is just what's happening out there, if you will. This is from the SRTR data. And so there were 17 retransplanted patients following dialysis. Only one of those had a nephrectomy that was BK positive. I do not have the outcome. I will tell you that it's interesting talking to some surgeons around the country. Some people believe that if you get a preemptive second transplant and you lost your graft due to BK, that you should have a nephrectomy. Now, as you can see there, 4 had a nephrectomy here in this series and only 1 did not. Some people have moved to continue to check for viremia, and if you clear your viremia, you don't need to do a nephrectomy, but if you do not, you do need to have a nephrectomy. And I'll be honest with you, that's sort of where Robert Harland is today. But just keep this in mind if you have somebody who is misfortunate enough to have lost their graft due to BK. The guy from, there's a patient we have who we actually had a lost graft, and actually he's already had his nephrectomy, so that's not going to be an issue for him. There is increasing evidence that chronic shedding of BK virus actually can cause bladder cancer. So those patients and I can think of a couple of patients that really worries me. There's no recommendation, but I'll be honest with you, I know in one of these patients I have already done urine cytologies on them once. But if you had a patient, and you've seen them, the guys that get down to 120 copies and you can't quite get them any further, I think those are patients you probably should screen them with at least urine cytologies from time to time, because there's developing evidence that BK is associated with urogenital tumors. And in the interest of time, I won't dwell too much on this slide, but just to tell you that, again, and I should have looked this up today, but I just didn't get time enough to do it. There are potential cost savings to be had if you can prevent somebody from losing a graft. So we will do the math on this, and like I said, we may move to some kind of combination of looking at viruria and viremia. And this conveys terribly, and I apologize. It's almost a Jimi Hendrix kind of picture here, but you know, we, gosh, I haven't given this talk since last February, and we've not done much with this to cast stones at myself and everyone else. But Reggie, you know, we were talking about replicating the Brigham study in a more prospective fashion. I do think whoever designed this, and I can't remember if it was you or not, Reggie, I'm picking on you, I do think it is going to be very important to separate out the thymos versus similae, because there is a risk factor for having been induced with thymo. And what we do after so many days and switching them back to separate, whatever, I think we can talk about that. But I feel very comfortable considering the trials that we have people on. And now, of course, we're using some everolimus, so that might be a problem. But it would be a cool thing to look at. And I think